Hey NCS podcast listeners, this is your host Fawaz Al-Mufti from Westchester Medical Center, New York Medical College. Desperate times call for desperate measures. This is especially true for many of us in healthcare, as we find ourselves adapting to new roles and new units, innovating to tackle a new disease while adjusting to a new surreal reality. Hence, in an effort to reestablish some degree of normalcy, we decided to resume the release of our episodes on the NCS podcast. As I say, the show must go on, and at least now you can listen to something that is non-COVID related for the next 20 minutes. Over the last 20 years, the inclusion of advanced practice providers in critical care departments has allowed them to emerge as invaluable, ever-present team members, crucial to the continuity of care and a stabilizing force for intensive care units. As such, the integration, advancement, and education of advanced practice providers is essential to maintain a high-functioning neuro-ICU. We're excited to collaborate with the NCS Advanced Practice Provider Leadership Section to launch the NCS Advanced Practice Provider podcast miniseries. Over the course of 5 episodes, we will discuss a variety of topics ranging from APP utilization and staffing models to billing practices, and hopefully present ways by which intensivists and forward-thinking advanced practice providers can work together to optimize the daily functioning of the neurocritical care units. I hope you enjoy this episode.
Hello, and welcome to the Neurocritical Care Society podcast APP miniseries. I'm Thomas Lawson, and I am a nurse practitioner currently practicing at the Ohio State University's Wexner Medical Center Neurocritical Care Unit. I'm also a member of the NCC APP section. It's a pleasure for me to introduce Tamara Langley, the Director of APP Services and Critical Care Medicine, which includes neuro and surgical critical care, and is the APP Fellowship Director for Critical Care Medicine at the University of Kentucky, as well as being the current president of the Association of Postgraduate APRN Programs. She joins us for a discussion of her recently published article entitled A Comprehensive Onboarding and Orientation Plan for Neurocritical Care APPs. Tamara, thanks for joining us on the Neurocritical Care Society's podcast.
Thanks for having me.
You wrote this article about the onboarding and orientation process at UK. Could you summarize your 3-phase orientation for our listeners?
Sure. Phase 1 is fundamental critical care support. It's 2 to 4 weeks, and that again depends on what your background is in ICU or in generalized patient care. And that is just the basics, of course, of critical care. Just kind of get you a decent stepping stone. So after that, after you finish phase 1 and you say you're ready to take the test, you take an online exam. Once you pass that exam with a score of 85 or better, you move into phase 2, which is critical care medicine. Now this lasts 2 to 3 months. And again, since it's self-directed, you can go through it as quickly or as intensely as you want to. But we do expect you by, 3 months that you're ready to take that exam. And that is really diving into a solid understanding of critical care. Then after you finish that phase, there is another online exam. And once you pass that exam, you have an oral review with 2 physicians. And when you successfully pass that, you move into neurocritical care specific. And then that phase is focused on really understanding the specific and unique needs of neurocritical care patient populations. And then at the end of that, you can look forward to another exam and another oral review.
All right, sounds good. What type of difficulties were you having that led to the development of a program structured in this way?
Well, it's really funny, and necessity is the mother of invention, right? About 6 years ago, a new division was born out of critical care medicine, which was neurocritical care. And part of that is that Dr. Kevin Hatton, who was a division chief, knew that he was going to be hiring in lots of APPs that did not have critical care experience in neuro. So that is where the thought process came of how do we onboard and make sure that everyone understands how to, number one, just do basic critical care, and then build on that to take care of neurocritical care.
Yeah, I think that's that's an issue that a lot of us have run into in specialty ICUs. Now, with the growth of postgraduate fellowships in critical care and in other specialties, how do these interface with the program that you described in this article?
Well, so the orientation program came first, right? So everyone went through, all the APPs went through this program working. And then we started to look around, and some of the other universities were doing fellowship programs. And actually went to Emory and saw their fellowship program and thought that this would interface perfectly for APP fellows to come go through the orientation program, and we'll just kind of stretch it out and make it more intensive, add a few more aspects, and really offer a well-rounded educational opportunity for those that would choose to do this.
So people who are recent graduates of a general critical care fellowship would then enter this program?
No, we take brand new graduates from school, and then they come here. So we have two aspects, two APP teams. We have neurocritical care, and then we have a surgical critical care. So everyone starts in the neurocritical care, and they spend 6 months, and then they move on to surgical critical care, and then they spend about 5 months there before they go on to an elective.
Okay, interesting. Can you walk us through your interview process and how you would screen a candidate with clinical scenarios?
Yeah, so everyone that comes in, we try to choose people that have a critical care background, whether it's as a bedside nurse or someone who's worked in critical care previously, just so that people have a basic understanding of how an ICU works. So we have a panel interview, consists of about 6 people. 2 of those are physicians. And then we have 2 clinical scenarios, one for each physician. And basically, one of the neuro questions, without giving too much away for our applicants, is that you receive a patient post-thrombectomy, and their blood pressure is 70/30, say, and then the next question is, what do you do? And the basic questions of that are, do you understand what could have possibly happened? Are they dry? Could they possibly be bleeding? And it's really to determine the candidate's thought process and to see how they make clinical decisions. And then everything that they offer as possible intervention, the clinical scenario follows what they've done, and the patient will either get worse or a little bit better, and then they move on to, the next hemodynamic intervention or possible catastrophe.
I can imagine you get a wide variety of responses. And I know sometimes when I ask more junior APPs clinical questions like that, it's easy for the question to turn into a what am I thinking question. So how do you go about evaluating their responses?
Well, it's really interesting because we've had some very strong candidates that were really super strong ICU nurses come in and not do well in this. So say the patient's SATs are 88% when you walk in the room, basic questions like that, we expect put them on a little bit of oxygen first. And it seems like people will jump straight to, well, I'm going to intubate them. When in reality, the first thing you would do when you walked in the room, of course, would be if they're not on oxygen, put them on oxygen, give them a little bit more oxygen, if they're not struggling. So that has been interesting to see people assume that we want you to do the most aggressive intervention when really that's not true. We just want to see what would you do as your next step.
Sure, I agree. Sometimes it seems like people, like a more experienced or a stronger person allows for a little bit more nuance and not being quite as aggressive as early.
Yeah, I completely agree. And I think nerves, of course, especially nurses, are not used to those types of interview scenarios. And we prepare everyone before they come that they're going to have these. So it's not like they're surprised. But nerves take over. And they want you to, I think, show that they know that if a patient's in respiratory distress, they need to be intubated or something similar to that. When that's just not always the case.
So along those lines, in the article, you summarized a three-phase orientation process in which the APPs would, to graduate out of the second phase and then to graduate out of the third phase, needed to pass both a written and an oral examination. And I thought it sounded pretty intense. How have employees in this program felt about this style of evaluation?
Well, everyone's always super nervous, of course, and our physicians are anesthesiologists, and they have to do oral boards as part of their, passing and working. So it is not unusual to them. So that is why it's been incorporated into our orientation process. So everyone knows that, coming into this program, that these are the steps that you have to go through. And if we go back to the interview process, it's very similar. Only this time it's two physicians and just the candidate or just the APP sitting in a room with them. And then the APP supervisor sitting off to the side, kind of listening and grading. And it is extraordinarily intense. They're very good at not giving away clues as to whether or not you've gone down the right track. No nodding of the head or smiling, which makes it just 1,000 times worse. The great thing about this is when you come through to the other side, now, there are people that don't pass it, and that's okay. But for those that pass it the first time or the second time, as the provider, the APP provider, when you finish that, you know what you know. You don't have any papers with you. You're not phoning a friend. You're not asking another APP. You're able to answer these questions and work through clinical scenarios. And, of course, you have months of experience now to pull from. And they're usually just like, whew, so glad that's over. But they also feel, confident in their decision-making abilities.
Yeah, I could imagine getting through something like that and just feeling this, I did something hard and intimidating, and I crushed it. And then that being the confidence booster moving forward. Yeah.
And it's a two-part, especially when this program was developed. There was one physician in-house in the evenings, and when Dr. Hatton created this and, implemented these exams, it was not only to know, what do they know clinically, but how do you respond under pressure? And that is why, number one, the interview process is as hard as it is. But it's also to gauge, too, as you're progressing along. If you're alone at night and it's 3 o'clock in the morning and your patient codes and help is not right there, how are you going to be able to respond? Are you going to end up in a corner crying, or are you going to be able to step up and say, this is a hard situation that I'm in, but I am okay until help arrives?
That's cool. I've totally been in that situation. It's neat to get through it. I want to go back to the interview part. You explain in the article that the candidates are told in the interview that a significant commitment is required, specifically being studious during off hours. Do you have a way to assess this, or is it more of a warning and a laying out of expectations?
Well, the first phase is you should be taking your test within 2 to 4 weeks. If you haven't studied for that, you're going to fail the test, and it's an electronic test. So that's one way we would know. But also, as you're passing into phase 2 and 3, and you're getting into more specialized care, we know there's a study guide with chapters and readings, so the team knows where you should be and what your expectations of understanding are. So when you're rounding, your questions should be able to reflect the fact that you're gaining more knowledge, not only in on-the-job training, but in your education. So questions will relate back to what phase you're in. So when you move into neurocritical care and how you're treating the more advanced subarachnoids or other TBIs, your understanding of that patient's physical problem should reflect where you are in your readings as well.
Do you have a way of screening out people before they're given a job offer? Is there a way to find people who aren't going to cut it?
Well, honestly, the clinical scenario screens out a lot of people, and we can tell pretty quickly basic medical knowledge, number one, and we don't expect them to be provider level, even a year out as far as their education, but basic understanding of how an ICU would work is, and that the pressure put onto them is very, very telling. And we have moved with the fellowship. We don't hire brand new providers anymore directly into an APP spot. They usually go into a fellowship spot. And no one is going to apply for a fellowship, in our opinion, that doesn't expect that they're going to have intensive training and exams. There's no way for us to truly, watch what they're doing. But we explain that, we have a really high expectation that they are studying at home and prepared for the exams. And honestly, we've had people walk away and say, this is really not what I'm looking for.
Now, you mentioned that you have the expectation that candidates will possess ICU clinical experience as an RN. Now, given that the educational pipeline for physician assistants is different, is there an equivalent expectation for PAs?
So that's a harder spot, and that's been lots of conversations that we've had recently, because we want to be inclusive of PAs and NPs and make it a true APP fellowship. So what we look for in candidates is that they've had clinical rotations in ICUs. We're a level 1 hospital. We're a certified stroke center. It's fast-paced. We have, 24 beds just in our 2 ICUs that stay full a lot. And not only to rule out PAs if they don't have ICU experience, we would also rule out nurses that don't have a strong understanding of how an ICU would work. But we want to be supportive and inclusive to the PAs that are choosing to take ICU rotations. We want to be able to include them.
Have you made any notable changes to your hiring and orientation process since publishing this article?
I think the biggest change is that we have moved to the fellowship. When we published this was strictly for advanced practice providers coming in, being full providers at the end. And what we did was then stretch this out into a year-long program, specifically for the fellowship. We've added different components for the fellowship. We have sim labs and more online education or education that's been recorded by us from people in-house from previous years of our fellowship to be incorporated into it. So the fellowship program now, compared to when the paper was written, has more educational components than the paper does.
Now, in closing, is there anything else that you think is particularly germane to this discussion that we missed?
I don't think so. The world has changed a lot in the last 10 years of onboarding APPs. I think when APPs started really coming onto the scenes, a lot of people assumed that our education would match any job. And I think the reason I was drawn to work for critical care was because they had this orientation program. Because our education, especially as nurse practitioners, is so bad. To have something that said, this is your patient population and these are the specific things we need you to know and understand about this patient population was very attractive to me. And I think that's something that's changed a lot and is continuing to change within our profession for NPs and PAs, that our patients deserve that each provider understands and is well oriented into that specific patient population and their unique needs.
Well, Tamara Langley, thank you for taking the time to talk to us.
Thank you so much.
The NCS podcast series is produced by the Neurocritical Care Society, whose mission is to promote quality patient care, professional collaboration, research, training, and advocacy in neurocritical care. Our production staff includes Fawaz Al-Mufti, Ramani Baloo, Mike Brogan, Josh Levine, Benjamin Miller, Sterain Shepard, Jim Siegler, Sarah Sternnezer, and Chris Zammit. Our senior producer is Bonnie Rousseau. Our administrative staff includes Bonnie Rousseau and Angel Gindel. Music is created by Mohan Kadapali from the Division of Neurocritical Care at the University of Miami. The NCS podcast series is available on NCS On Demand and wherever you may listen to your podcast. For more information, please follow us on Twitter @Neurocritical or on Facebook. I'm Fawaz Al-Mufti, and thanks for listening.